Sir, are we ready to go live?
Yes, please.
Okay, sir. We are going live in 5 seconds. 5, 4, 3, 2, 1. Sir, we are live now.
Thank you, Marshi. So, good morning, everyone. And in today's Fellows teaching module, we are going to discuss a very tricky pathology, fracture neck femur, which is relatively less common but very complex. And we have my dear friend, Dr. Thomas, who is also a Kids alumni. So we share that that thing in common. And Dr. Thomas is he will take us through neck femur fracture. I'll invite Goda and me to moderate this session. We have very interesting cases at the end by Dr. Chinmay Sangole from Amravati and Dr. Tashfeen from Bangladesh. So Goda and Meet, you can take over now.
Yes.
Yes.
Good morning, sir. Today we have Dr. Thomas Palocaren as our faculty. Sir is professor in Department of Orthopedics, Christian Medical College. He's a well-known pediatric orthopedic surgeon. Sir has done his fellowship in pediatric orthopedics at Hospital for Sick Children and from Alfred DuPont Hospital. He's a faculty in various national conferences, and he has presented various national and international publications and presentations. He has trained numerous postgraduate and pediatric orthopedic fellows. So we welcome you today, sir. Thank you.
Okay, thanks for that very gracious introduction. So I'll share my screen. So I thought since all of you are past the undergraduate stage, I will first start with a few case discussions, and then I will go on to the presentation. So I've chosen 3 cases. I've chosen 2 with complications, 1 for its technical expertise. And as Maureen said, Kids was one of a big teaching experience that I had. So this is a 1.5-year-old child who came to us. The parents noticed positive movement of the right hip. They didn't give any history of trauma, but in a child who's less than 2, you always have to be worried about non-accidental injury. So this, as you can see on the X-ray, the physis is a little off. So we put the child, took him to theater, did a close reduction, and after spica, and then 4 months after spica, that was the appearance in the low down right. It's not a very typical transphyseal separation, Delbet 1. So I'll show you another one where, so this is a child, an unstable skiffy also, because the slip occurs at the transphyseal level, is an example of a Delbet 1. So this child was an 11-year-old boy who presented it with pain and inability to stand unsupported. The X-ray showed a slip, unstable slip on the right side, on the left side, sorry. So we don't do a cross, we can do a cross table lateral, but you should not do a frog lateral in such cases. So this is how we pinned it in situ. So although there are other methods to anatomically realign, it requires a learning curve and risks of causing vascular damage. So we go with the tried and tested gold standard of in situ pinning. This is the way you pin a severe slip. Put a guide wire, aim to the center, and pin it from the anterior aspect of the neck almost. And you use a fully threaded screw, 6.5 screw. Do it on a radiolucent table. And that is a picture 2-year post-op with remodeling. A little bit of bump, but he was functional, didn't complain of any femoroacetabular impingement. Now, this is an example of Delbet 2, a 15-year-old boy. Most of these fractures occur due to high velocity trauma. Either in the Indian scenario, when I reviewed a few years back, most of it was due to motor vehicle accidents, road traffic accidents, or fall from height. Those were the two predominant modes of injury. But here, this child actually had a violent tackle, I think, while playing kabaddi, and had this fracture. So you should be aware of this fracture in the Delbet 2 transcervical, which is the commonest, and also look out for this oblique fracture line. That obliquity is a little bit of worry. So we took the patient to theater. We did a close reduction, intra-op images, and a fairly good reduction we got on the APM lateral, and pinned it with 3 screws. Usually 2 screws are enough, but this child was a little big adolescent, so we could get in 3 screws. That is 10-month post. Yeah, so that is a 10-month follow-up. Can you see some worrying features on the right side? Some sclerosis, loss of joint space. So this child is developing avian and probable chondrolysis. At that point in 2009, we had just started a surgical hip dislocation after Teddy's Longo and young Joachim had come here to show us the method. And we were a little aggressive on this child. So as soon as he developed avian and chondrolysis, we actually did a surgical hip dislocation, did a capsulectomy, debridement, and we did micro drilling from the articular side using a 1.2 KY, which helped in decompression. And that was a 2-month follow-up. And he was regaining range of movement with the CPM. And along the course, we also gave him pamidronate. And this is the follow-up 6.5 years later. He was fairly functional. Only most feared complications of fracture neck is avian. And this is avian in children can be tackled. And this is what happened to this child. Now, this is the third case, which is we can call it an intertrochanter. You can see the trochanter also involved. This is a Delbet 4. And this child actually had a coxa vara, already had a fracture prior to this at the same location, had native treatment. I don't have the X-ray on the other side to compare this also some time ago. So at that time we used a pediatric DHS, stop short of the physis. And this is a 6-month AP and lateral use. Now down the line, we had some trauma and he came back with us like this, with a fracture just below the plate. So what did we do? We extended the DHS and put a longer plate, incorporated the fracture, but didn't correct the neck shaft angle. 5 years later, he again came following a fall, had a fracture, and by now he had become an adolescent. Then we did an rigid IM nailing. And then 15 years later, he's now presented to the adult side with fatigue and pain on walking long distances. You can see that the neck shaft angle is still less than 120, what we'll call a coxa vara, and that predisposes to osteoarthritis, as you know, in later life. So what I'm trying to convey is sometimes you have to look at the larger picture in pediatric orthopedics as the child grows, even into adulthood. A big component of our practice is to look to the future and also tailor your treatment accordingly. And these are the complications that are commonly associated. Avian, which is dreaded, coxa vara, as you come down to Delbet 3 and 4, and non-unions and delayed unions.
So Thomas, in hindsight, would you have fixed this coxa vara while you were?
So again, you will have to again tell the patient. The problem in our setting is sometimes the patient doesn't want the other problem fixed. So if you tell them, see, you have to fix your fracture, then also correct your biomechanics. Very few patients actually understand the need for a double procedure and also one which is not, in their view, not so important. I think if you are practicing abroad, I'm sure, yeah, we will have to do the biomechanics also, but very often they don't allow us to do, let alone on this side. Even a contralateral skiffy pinning, sometimes they don't let us do on the normal side.
Yeah, that's right. Fine.
Okay, we can have any questions on these three cases we can have before I go on to the presentation.
So one thing I would like to ask, what is the reason of chondrolysis in the neck femur fractures? I mean,
yeah, I was wondering whether I went back and looked at the operation notes, whether there were multiple attempts, whether the guide pin penetrated, but there was no notes on that. So one of the reasons is if you penetrate iatrogenically, if you use your guide wire and over enthusiastically cross the cartilage, cause chondrolysis iatrogenically. But avian itself can cause synovitis and chondrolysis, I think, early. Even we were lucky to have caught it early and addressed it quite aggressively. And I think with CPM and with pamidronate, I think the results 7 years down the line are quite gratifying.
So I think avian causes the cartilage to become weak, and that leads to chondrolysis.
Yeah, there's not much literature about how, but sometimes both of them can coexist.
Right. Okay, I think we can take questions at the end of your talk.
Okay.
And by that time, more people would be there and we'll have more questions.
All right. So fracture neck is a rare injury. There are no epidemiological studies the last decade, I think, when I look back in literature now, because it's a rare injury, it's very difficult to do some level 1, level 2 studies. So most of them are small case series or level 4 evidence. So, and also the problem of the complications is quite high with this fracture. That's why the importance of knowing the anatomy and treating it accordingly. And as I said, in the Indian scenario, the mode of injury is fall from height and road traffic accidents, which predominate. You can also have low energy injuries following a pathological fracture or a stress fracture, and that requires little more knowledge and awareness, and also little more imaging, maybe an MRI or a bone scan to pick it up, and the awareness that this can happen and to look out for it. Actually, there's a syndrome, female athletic triad, when athletes who have osteoporosis and who athletes with amenorrhea can have the stress fracture. So you have to look out for them, and they say, at least the literature says that you have to look out for them in young female athletes. So when these patients come to the casualty, you have to, after doing a primary survey, during a secondary musculoskeletal survey, you have to look at the history, whether they can bear weight, whether they are unable to bear weight, whether they have a shortened externally rotated limb. Also, because these are high energy trauma, you have to look for other systems injury. There's around a 25% probability of another system injury with a fracture neck. Also, as I said, non-accidental injury, 80% of fractures under the age of 2, you have to rule out non-accidental injury or battered baby syndrome. So we immobilize these patients with bucks traction, simple skin traction up to 2 kilos, maybe 1.5 kilos with a pillow, and counsel the parents about potential risks, consequences of injury and treatment before taking them urgently for treatment. How does it differ from adults? One is high energy trauma, thick periosteum, require significant force in children to cause a fracture. And also there's a difference in blood supply between adults and children have an open physis. So this is a diagram I drew in my review a few years back. And there are 3 phases: the birth phase till the physis ossifies, and on the physis ossifies till the skeletal maturity. And each of those phases have peculiarities of blood supply. So once the physis forms at 6 months, the transphyseal vessels stop. And between the ages of 4 and 8, there is a diminution of blood supply from the obturator artery, which is the ligament of TB. So between 4 years and 8 years, children have a tenuous blood supply, which is totally dependent on the lateral epiphyseal vessel, which is a branch of the medial circumflex femoral. And after 8, slowly there are contributions from the artery of ligamentum teres, and the adult pattern takes over. So blood supply, knowledge of this blood supply, and also that you do an anterior capsulotomy, avoiding the supralateral corner of the lateral epiphyseal artery, also important when you do a open reduction. So this is the Delbet classification, which is a long time back, I think in 1928, popularized by Colonna, and 1 year later, which are these 4 types. The transphyseal, transphyseal can be divided into A and B without dislocation, and with dislocation, with the avian rates are higher. And transcervical, which is the commonest. Then cervicotrochanteric, which is basal, and intertrochanteric. And as you come down the grade 3, grade 4, the chances of avian come down, and the malunion rates go up, and Coxa-Vara rates go up, as is shown in this slide. And this is taken from the latest Lowell and Winter 2023 edition, where the avian rates, according to that, is in the dislocated type can approach almost 100%. And if it's not dislocated, it is variable, is what Lowell and Winter says. The transcervical, which is the most common, can have 50 to 60% avian rates. Cervicotrochanteric, 30%. And as you come down, which is extracapsular, you have only 10% avian rates. And there was a study by Moon et al., which showed that as you progress from the intertrochanteric type, so the transphyseal types, the odd ratio, it has 15 times more likelihood of having avian. In the transcervical type, you have 6 times as possible or as likely to have avian, and 4 in the cervicotrochanteric or the basal type. So this is an example of a transcervical type where 2 screws were used. And there's a reduction criteria by Song that talks about displacement and angulation, what is acceptable, not acceptable. And you can use advanced imaging like 3D CT. And now there are studies which imaging with MR, perfusion imaging, or SPECT scan to even study vascularity. And as I said, treatment, younger children less than 3, you can do a closed reduction. Sometimes use smooth pins across the physis. Most often we immobilize with a spica. In a children little older, we can use cannulated screws, 4.5. And in a much older child, you use a 6.5 screw. And if it's basal or a Delbet 4 intertrochanteric, you can use a side plate device. Previously, we used to use a pediatric DHS. Now there are better implants. You can use the Synthes proximal femoral plates. And if you do not get an anatomic reduction, I think it is now there's literature to say that you should attempt an open reduction and get good anatomical reduction, which in some papers say reduces avian rates. Now you can do the surgical approach by either of the 2. If you do a Watson-Jones, you can use the side plate in the same incision. If you use a Smith-Peterson like you do in DDH, the anterior approach, you may have to use a stab incision laterally and put percutaneous screws, or you can even open and do a lateral separate incision for your side plate device. And there is literature to show that the modified Smith-Peterson approach provides a superior exposure and better visualization, especially of the medial neck and the lesser trochanter. So this is a basal type, which I already showed you one example. You should also be aware of this vertical shear or the oblique type, where the shear forces can displace your fracture even after reduction with pins. So sometimes you can do a primary valgus like we've done in this case and fix the fracture. Coming to special situations like, as I said, stress fractures and pathological fracture, you can have an aneurysmal bone cyst or special conditions like osteoporosis, osteopetrosis, or marble bone disease. Then in stress fractures among athletes, where you need some advanced imaging. And as I said, non-accidental injury or child abuse, less than 4 years. 1/3 of all femur fractures, less than 4 years, is a big number for child abuse and non-accidental injury, which sometimes in our country we are not so aware of. This is a patient with osteopetrosis with dense bone, and we actually can see we had to use of several drill bits, and some drill bits broke. Those days we didn't have better implants. We used DCP and bent it. So the complications, as I said, the dreaded one is avascular necrosis, which correlates to the Delbet types. It's also related to the initial injury, initial displacement and disruption of blood supply. There's evidence to say that there are some papers which say age more than 10 years and delay in treatment of more than 24 hours can predispose to this, but there's no consensus because, as I said, these are low evidence, not enough numbers, rare injury. So most of them are case series, and there's no consensus on the role of each factor. Whether it's aspiration, reducing the tamponade, or whether it's delay in treatment. So there's no real evidence on these each of these factors. And non-union rates, around 10%. You can tackle them with various methods. I'm sure Sandeep covered that in their previous. There's one complication of a late non-union for which we used an iliac crest, triangular iliac crest graft, put it in the gap, opened, then fixed it, then did a valgus. That is 6 months post-op and 2-year follow-up for a non-union neglected neck of femur. Now there are advanced imaging SPECT scan, where the maximum standardized uptake value is looked at, and this, if there is vascularity, whereas this, there is no vascularity. And there is advances in MRI imaging with perfusion imaging as well. So in a nutshell, these are rare injuries. Potential complications are devastating. Delbet classification is most reliable. Prompt reduction anatomical with internal fixation and decompression is recommended to restore circulation and to get union in a timely fashion and to reduce complications. Thank you.
Thanks, Thomas, for that lovely talk. And do we have questions?
No, sir. There are no
So
questions.
what is your immobilization protocol for fixation in adolescents, Thomas?
So if it's a Delbet 3 or 4, we don't immobilize with the spica at all. But if it is a transcervical or a transepiphyseal type, we do put a single hip spica for 6 to 8 weeks.
Right. And do you have a specific screw placement? What do you say?
Yeah.
The geometry? What do you prefer?
I think in the adults, I think there's not much literature in the children, but in the adults, there's inverted 3 and inverted V. But we can't get most of these necks, we can't get in 3 screws. So mostly we get only 2 screws.
Yeah.
So if you can get 2 screws itself is quite adequate, I think. And if you can immobilize, I think that should be quite a good immobilization fixation.
Right. And are you fancy of this reduction maneuvers for neck femur fracture if close reduction doesn't happen? Like, would you like to?
No, I don't. I see, as I said, the blood supply, as I showed, I think the blood supply in children is much tenuous, like in skiffy, in unstable skiffy, where these reduction maneuvers are no. I think even in fracture neck, you have to be very gentle. Maybe at the most 1 or 2 attempts at a gentle close reduction. And if that does not happen, I think you shouldn't have any hesitation since you are familiar with that by doing the
Open approach.
yeah, the anterior approach, I think I think you should move on to open reduction. You don't get a good anatomic reduction.
So Dr. Kutub is asking if you have to cross the growth plate with screw to get proximal purchase. So
Yes, that's I think correct. I think you have to give more importance to stability than the danger of physeal damage there. So especially in a transphyseal or a transcervical Delbet 1 and 2, I think stability takes precedence over crossing the physis or being scared of complications. I think stability is more important. So you should cross the physis and make sure your reduction is stable with by crossing the physis if it's needed.
So, Dr. Kutub, the growth, the average growth from proximal femur is 0.3 centimeters a year. So, if you happen to fix the physis, then you should follow these patients for long and to look at the limb length discrepancy. And if it is there, and if you have chance that you can treat them with contralateral epiphysiodesis, so that those children needs to be followed for longer time. Okay, I think let's move on to cases. Chinmay, do you want to share your screen?
Yes, sir. My screen is visible, sir?
Yeah.
Yes.
Yes.
Good morning, and thank you for the opportunity to presenting my case in today's fellow meet. Myself, Dr. Chinmay. I'm a pediatric orthopedic surgeon currently working in Dr. PDMC Amravati and shortly opening my own private clinic in my hometown. So today we are discussing about femur neck. Adolescent age group girl was presented, had a history of fall while playing, and she was unable to get up and unable to get up due to the pain. For which she took her parents took her at a local hospital, and they give the treatment in the form of X-ray and some medication. And they were referred to a higher center for to get surgically treated. But due to some logistic issue, they presented to me after 5 days. So they came up with the X-ray, which I shown in this slide, which shows the. In AP view, we can see there is a broke in a sentence length. At the same time, there is an overlap of the proximal and a distal fragment. In a lateral view, we can see there is an anterior spike of the proximal fragment. So we can classify this as the type 2, that is transcervical fracture. So before going into it, there are a lot of questions came into my mind as a young pedipod. So what will be, because we have to see beyond the Delbet type classification, as sir rightly mentioned, we have to see about the angulation and translation. Yes, because the angulation and translation are directly or indirectly related with the avian rates of the neck femur fractures. So recently published paper in 2019 suggested that translation more than 35 to 40% in AP diameter in an AP view will directly correlated with the avian rates of the neck of femur fractures. At the same time, what will be the acceptable criteria, anatomical landmark, like in a lateral view, we have to say the lowest S sign, the approach, because I always think that putting a guide wire through a soft tissue will bend the wire in between the passes through the neck. So I always think about to go with a mini open from lateral side and to put the guide wires. Implant choice, of course, the CC screw will be fine for this child. The screw configuration, what will be the screw configuration placement from the piriformis? Because the recently published literature in JPO 2022 suggested that the distance from piriformis fossa of the superior screw should be at least more than 50%, because the most of the intraosseous blood supply get hampered when we drilling the neck of femur, and which is directly correlated with the avian rates, which they statistically prove significantly in their paper of 153 cases. Post-op immobilization for 6 to 8 weeks, non-weight bearing at the same time, and in a follow-up, I'll follow the SONGS criteria to look for any translation or any angulation in this patient.
So Chinmay, before you go ahead, like, this seems to be an interesting paper.
Yes, sir.
Effect of number, size, and location of screw. Now, location, you said from the piriformis fossa, how much the proximal screw should be at what distance, you mean?
Sir, they define the criteria of 50%, 51.6%, sir. Because
What is
if you go close from the piriformis fossa, they give the reason that intraosseous blood supply get hampered because they define that 3 blood supply is important for the neck of femur. One from the middle circumference, one from intraosseous, and one is from the ligamentum teres. And they shown the cases that when they go close to the piriformis for the placement of the screw, that is directly correlated with the avian rays.
So you mean that the proximal screw should not be too much near the proximal cortex, proximal neck?
Yes, sir. So they advise to go for mid-inferior region rather than going to mid-superior, go little mid-inferior regions.
I think
Okay,
he's
the
talking
next
about
thing
the,
is, so that means that's an inverted V, but the top screw should be little away from the superior cortex.
Yes.
And what about number and size?
So they were like a two cc screw, as Thomas sir instead of 2 cc screw will be fine for it because with the 2 cc screw the avian rates are less. But sometimes you have to put 3 cc screw because considering the neck width in the lateral view, you should be not overfill the neck width with so much of cc screw in it, which will directly hamper the avian rates of this child.
Okay.
I think the other consideration, Morgan, is the Chung's arterial ring at the base of the neck. So I think that's what he's referring to. But sometimes you can injure that even in a basal neck or a cervicotrochanteric fracture. So if you place that screw a little more superiorly, you can injure that arterial arcade ring at the base of the neck also.
Okay.
So this is the same study, sir, they conducted for 2019, 20, 19, 20, and 22. So they started the study from CCOT, then they published in JBGS, and then they published in 2022. So they have an extensive follow-up of around 240 patients, sir, for the neck femur, and it's a multi-center study. And one of the authors is Federico Canvas, sir, also one who presents.
Federico does this mission trips in China, so he visits China. Yeah. Okay.
So in the OR, I give a traction and a usual reduction maneuver. But when I look closely for the AP view, I see there is a vertical line orientation of the fracture line. So I have to think about the screw configuration because we know as putting a screw in a parallel manner will cause a shear force acting at the fracture site, and it will start collapsing and backing out of the screws. So this is just a diagrammatic representation which shows how the horizontal fracture line compressed with the 6 screw, and if the vertical screw in a vertical fracture pattern, if you put a 2 screw, it will start collapsing due to the shear force acting at the fracture site. So we have to put a one transverse screw to counteract that shear force. Taking account of this pattern and my thought process, I move forward and do a assisted reduction with a mini lateral approach, and put the CC screw in this manner that I put a one big screw in the for a calca to go up to the chondral surface, and a 4.5 mm CC screw which will cause the fracture site. In APV, we can see that this is the fracture line which is counteracted by the transverse screw, and which is almost forming a 90-degree angle at the fracture site to counteract and to prevent the collapse, and at the same time to counteract the shearing force acting on the fracture site. So as sir rightly mentioned, there is no much screw configuration published for the pediatric population, but these are the 2 papers which they publish for the adults, and they define that this transverse screw as a anti-shearing force screw, which will cause the compression, at the same time will not cause the proximal fragment to go into the varus position. So in a post-op, as this case I have mentioned in last time, so sir advised me, Mohan sir advised me to give a non-weight bearing, at the same time the immobilization in 1.5 spica for 8 weeks, and I took the X-ray for every month, and after 6 to 8 weeks, I started the static quadriceps tendon exercise and bedside knee mobilization. And in successive follow-up, this is the follow-up X-ray of this child, immediate follow-up. This is at the 1 month. This is at the 2 month. This is at the 5 month, and we can see clearly there is a good union at the fracture site, and maintenance in a lateral view also. So according to SONG's criteria, it's come under the excellent remodeling of the fracture site, and I think the trick is here to remodeling of this fracture is because of the transverse screw I placed in the fracture for the fracture vertical fracture anatomy, and I think that gives the a good and stable fixation for this fracture, and the fracture healed well. So this is the functional assessment of this child. So we can see she clearly do a cross-legged sitting, and she able to do a squatting without any pain or without any discomfort for this child. Thank you, sir.
Yeah. So that is nice case and good follow-up. The AVN sets in radiologically after 8 months, so we have to be watchful.
Yes, sir.
And if AVN is not there till 1 year, then I think we are through. What is your take, Thomas?
I think now with better imaging with MRI and all, you can pick it up earlier. But on X-rays, I think it takes about 6 to 9 months to find out
Yeah.
AVN. And there are patterns of AVN, no Ratliff's,
Yes,
3
sir.
types. So there are diffuse type, there's a localized type, and from the fracture line to the physis. So those 3 types you should look out for.
Sure.
Now, that's a nice thing that you need to put a transverse screw. The first thing comment from Dr. Kutub is that the transverse screw will not allow compression on weight bearing. So most important thing, the list amount of complications published in pediatric orthopedic literature is Jack Flynn's study, where they had list amount of complication, and they have immobilized all their neck femur fractures with hip spica. And I saw that study and I read that paper in details, and the highest age of the patient in their study is about 13 years. So even in adolescents, they have applied hip spica. So Dr. Kutub, we don't look for compression with walking in neck femur fractures. We want it to heal, you know, and the screws will produce compression, and the stability is very important. So we do not make them weight bear immediately after to have compression across the fracture site. We immobilize them, and that inadequate immobilization is one of the factors in pediatric neck fractures to have loss of reductions. You know, at the same time, Chinmay, we have done a few cases, similar fracture pattern, younger child with 2 screws, and that has healed. So there should be a you know, comparative study that whether you have the transverse screw has helped or not. At one point, we are discussing putting a lot of screw in young patients' neck is leading to AVN, and at the other side, we are seeing that it is giving more stability. So this needs to be compared, but that's a good outcome. At least we want good outcome in all our patients. So keep us posted about what happens. And if at 1 year child is doing well and X-rays are okay, then I think we are through.
Yes.
It's a good case. Thank you. And
Thank you,
good literature review. And this papers you should share on fellows module if you have PDFs.
Yes.
Yes, Dr. Tashveen, please share your screen. And Chinmay, what is mini open from lateral? So is that Watson-Jones approach you have taken?
I just need to see the bony bones, sir, from lateral side, because when I put the guide wire, it will start bending. So that's why I need to open from lateral side, not on Watson-Jones particular approach, but just a mini open the way we do for the DHS plating, just literally to put the guide wires from the bone directly bone to the plating.
And I saw an artery faucet.
Yes, sir. That is going
something to lever this, I think.
Yes, sir. To lever that reduction, sir. To assist the reductions.
Okay, fine. Yes, Ashwin, please go ahead.
Thank you, sir. Sir, slide is visible or not, sir?
Yes, yes, it is.
Oh, thank you, sir. Good morning, everyone, and thanks for giving me the opportunity to present some interesting cases in my country. This is Dr. Rubat Tashfir, working as a registrar at NITO in Bangladesh, and now I'm going to present the femur neck fracture in children. I have two cases, and it's not working.
There might be an arrow at the bottom of your presentation. You can start advancing from there.
Oh, okay. Thank you, sir. So case one is a 15 years old male, had a history of fall from height about 2 meters. After that, he is unable to bear weight and pain around the left glute region, and no other injury was noted. And then after having an X-ray, we found there is a fracture at a trans-cervical area region of the left neck of femur. And after that, we went for the operation. We went operative treatment. Post-reduction and interfixation was done by 4 mm cancellous carotid screw. And we used fracture table. One of the screw has partially crossed or touched the physis. And this is 2 weeks after post-operative. And here we see the reduction was done, and according to some classification, the SAR has told earlier it's less than 2 millimeter. And after 3 months of the post-operative, this was the X-ray showing there is a union was going on, and after 1 year, union was well achieved, and there is no complication. As sir mentioned, there is AVN or non-union. So this is case one.
So
And now,
Tashvin,
Sir.
if I inquire, like, I saw that your proximal most screw is quite away from the proximal neck.
yes, sir.
You know, I mean, that means that there is less span of your fixation, both in AP and lateral view. In lateral, we are all are in the center.
Yes, sir.
Have you started doing this after reading this paper referred by Chinmay, or
No, sir.
or is it your usual practice?
Usual practice, sir. We did as we in adult case, our senior teachers done, and in repetitive case we did in this way, sir.
Yes, Thomas. You know, I try to span the fixation.
Yeah.
My proximal screw is a little more proximal than this. How about you?
I think they say we should avoid the superior quadrant if possible. That so we try to put it one definitely along the calcar, just inferiorly, and one little more higher, but to avoid that superior quadrant if you can. So I think this core configuration is good. If you can manage 3 screws, it's very good, I think.
Yeah, and 3-4 millimeter screws. So you should have this length of screw also in your set. Where sometimes 4 millimeter set, they are short. So yeah, great. Okay, now go on to the next case.
So my second case is a 12 years old boy. He jumped from a wall, and after that, the same scenario, unable to bear weight, pain over the left side, no other injuries. And after having an X-ray, we clearly say there is a transcervical fracture neck of left femur. There's a Delbet type 2. And after we did emergency, initially we tried closed reduction, but we failed. Then we have to go for open reduction. And usually we did internal fixation by 4 millimeter cancellous carotid screw. And are you everyone is happy with this?
It's
with
more
this
like a
fixation?
Delbet 3, I think, more cervicotrochanteric than a transcervical.
So this is a very vertical fracture line.
Yes, sir.
That the Powell's angle is high, and the good thing is that you have went above the physis, so you have tried to have more purchase of your screws.
Yes, sir.
Sometimes, you know, the adolescents, they are like the bone geometry is like adults, and sometimes I feel that we should go for bigger screws of 6.5 or 7 rather than 4 mm. But your previous child was 15 years old, and you could get
Yes, sir.
away with 3-4 mm screws.
Yes, sir.
And yeah, these fractures are likely to get displaced So maybe as Chinmay suggested, a transfer screw might have helped here.
Okay, sir.
Yeah, but let's see what happens next.
Okay, sir. So patient.
One of the thing is, Tashwin, that the lower screw, all screws can be subchondral going bit in because the lower screw has less purchase. You are shy of physis, but
Yes.
your two screws have enough purchase.
Yes, sir.
Let's see what happens next.
So patient came after 14 days, stitch was off. At that time, he was non-weight bearing, and he came again after 1.5 months. And this was the scenario. This is the scenario. So what is next?
So the very important point is we should not allow these kids to bear weight till 8, and I'm very conservative because treating complications of neck femur is a hell of a job for not only for doctors but also for the family and for the child because they turn stiff. So I immobilize them, don't allow them to bear weight for 3 months.
3 months.
And it's a plain rule, you know, and so we should not, and we have to re-emphasize during our dialogue, the child should not put weight. It's very difficult because they are pain-free. They want to walk.
Yes, sir.
The same thing is for unstable slips. The children after 1 month, they want to run around, but we have to tell them that. So immobilization for longer period is one. And now you can see the screws, somehow there is resorption because earlier on the screws were looking, crossing the physis. Now they are looking shorter than the physis. So there's resorption and collapse or something, I don't know. But this would eventually fail.
Yes, sir.
So we have to do something. Thomas, what is your
Absolutely.
take now?
I think the immobilization component and the screw cutout, that superior screw there on the lateral, definitely there's some bending and screw cutout failure in after weight bearing, I think. So I think, as Maulan said, immobilization is very, very important in these children, where you wait till they sort of get stuck or get united before you even venture toe touch weight bearing.
Yeah, so now the Dr. Kutub is asking, should we have used a pediatric locking plate here? So yes, there is some people, they use locking plate or they use a screw outside the plate and a lateral plate and screws through the distal screws. But what I would feel now that this fracture was kind of having high Powell's angle.
Yes, sir.
With lesser space in the proximal fragment, there are higher chances of failure. So maybe you can wait, still you can keep the child non-weight bearing and see if the child is lucky, it may heal in a month's time. If there is further varus collapse, then you have to remove the screw. Why it is echoing? So yeah, you might have to remove the screw and maybe you have to do a valgus subtrochanteric osteotomy.
Okay, sir.
And fix it with a proximal femoral locking plate or whatever implant you are comfortable with. Yeah, sure. If you have further follow-up.
Sir, it's just last Wednesday he came, and this is the last X-ray, sir.
Yeah, so strict non-weight bearing.
So he came walking on his foot, and there is no, he can squat. There is no, as you mentioned, sir, there is no pain, sir. So he is just moving around or roaming around, sir. That he is pain-free.
The pain is not because your screws are holding. So some of them, they are pain-free. We have the child which we are going to fix today. He has been walking around for a week. Yes, with a neck femur fracture. It's a collapse fracture, but more and more you allow, they will go into the lateral view collapse, and you will see they'll come into a position of a slip capital femoral epiphysis. So I would suggest strict immobilization. If non-reliable, then put him then some plaster or something.
Yes, sir.
And if you are lucky, then in a month's time, it will start gluing. And you should see all this fracture line should be filled with the bone.
Yes, sir.
Otherwise, it will fail and then it will destroy so much the neck part. You will have to add bone graft and you have to open and all jugglery, you know. Now, at this point, if this remains same or collapse a little bit, you can remove the screw. You don't need to put graft. You just put a valgus plate and the things will be all right. So this is my opinion about this case.
Thank you, sir.
Thomas, would you advise something different?
I think you have to try getting union first, even if it's malunited in basal and intertrochanteric fracture, you can tackle that later, the biomechanics. I think the first primary important thing is to get union.
Sir, I have one question, sir.
Yeah.
Sir, when we say we need a compression at the fracture site, or it's good for a fracture under the neck of femur, is it important to maintain the neck length? Because compressing the neck length, becoming it is short or translating will king all the supplying vessel, and which eventually leads to the avian. So is it important to maintain the neck length?
You need to have good reduction. You need to have good alignment in both the AP and lateral. Most of the times we see that in AP plane it is well reduced and in lateral plane it is overlapping. And that is due to a mild rotational element. Usually we don't require too much of traction when treating neck femur fractures, but it's a rotational alignment. And at times there is, some soft tissue getting interposed in front and you are not able to reduce. So the question is, an anatomic reduction in both the AP and lateral is utmost important. One of the Chinese study where they have opened all the neck femur fractures and aligned it 100%, they have the list rate of AVN, even though they have done open reduction. So I think that's the key. And the compression means that should be well opposed to each other. If your bone fragments are not aligned 100%, then it will collapse. See, because the cortex will glide on each other. And that will lead to kink and all those. So it's the basic reason is your reduction, which leads to complication, inadequate reduction or suboptimal. Mainly we see all failures because adult orthopedic surgeons, they think that
Compression is
these are children, so they will do well in whatever sort of reduction it is. But we should have similar pattern of acceptance even in children as we follow in adults, In adults, we do not tolerate even a few millimeters translation. So here also we should be keen on that. Although we have been fortunate in some mal-reduced fractures, that we were fortunate to see a good healing, but it's not the case every time. So, and the complications are really stress producing on both the family's perspective as well as to us. So Tashfin, best of luck with this. And if you have not immobilized well this child, then call them back, the family, and ask them not to be away. Otherwise, it is going to produce a lot of issues.
Okay,
fine.
sir.
I think if we have any question, we'll take. We have a few minutes, or otherwise we'll wind up. Thank you everyone for your participation. Thanks Thomas for lovely cases. That 15-year follow-up case was really eye-opening of Coxavara. Very nicely managed.
Thank you, sir.
Thank you.
Thank you, sir.
So, take care. Thanks, Thomas.
Okay, thanks.
See you all this Saturday with a nice journal club. We have 4 very interesting papers, and I think that would help all of us. So I'm stopping the recording first and then